I'd like to start by thanking the organizers for the invitation to present a talk, which they asked me to cover, the ideal immunosuppression after liver transplant for hepatocellular cancer. In terms of disclosures, I will be mentioning off-label use of mTOR inhibitors in liver transplant. And the objectives I'd like to set out are, first of all, does choice of immunosuppression have the opportunity to alter outcomes after liver transplant for hepatocellular cancer patients? And what evidence exists in the literature to basically look at an impact on HCC of the various anti-rejection drugs that are currently in use? And to use this information to try to build an argument for what I would propose as an optimal immunosuppression strategy for patients undergoing liver transplant with hepatocellular cancers. Our goals of immunosuppression, of course, are to control the immune response, to have a manageable rate and severity of acute rejection, and therefore hopefully no graft losses due to rejection, and to achieve this with an acceptable toxicity profile. In parallel, what we would like to see in these HCC patients is a reduction in tumor recurrence that would translate to an improved tumor-free survival and improved overall survival. And the question then is, can tailored immunosuppression help us achieve these goals? So I'll throw out as a bit of a straw man what I would propose as the ideal immunosuppression: steroid-free, induction with anti-CD25 monoclonal antibodies, minimization of calcineurin inhibitors, and relying more on mTOR inhibitors for long-term maintenance immunosuppression. So what evidence do I have to support this position? Well, the information in the literature in terms of the impact of steroids in this area is relatively limited, but it includes this time-honored paper from Tom Starzl's group many years ago that revealed that patients who had a recurrence after a liver transplantation in the presence of immunosuppression with cyclosporin and steroids basically had a marked reduction in their tumor doubling time compared to patients who had recurrences after resection. And in fact, that impact was about 7-fold. A more recent study from China has looked at the impact basically of 368 patients in the China Liver Transplant Registry who underwent liver transplant for HCC and received steroid-free immunosuppression, and compared that with a double-sized group matched for propensity scores, basically patients who were on steroids. About 2/3 of these patients were within Milan and 1/3 beyond. And as we can see here, basically, first of all, there was no benefit seen in patients beyond Milan criteria in this study. But in those that were within Milan, we see that the steroid-free patients had both a better overall survival and tumor-free survival when compared to the patients treated with steroids. Another paper here that looks really at the impact of the potency of immunosuppression we utilize in these patients on HCC recurrence. And it demonstrates that patients that received induction therapy with ATG or OKT3 had a substantial impact on their overall survival, and it was in the range of the same area of poorly differentiated tumors or tumors that were beyond 5 centimeters. So immunosuppression certainly does seem to have the potential to have an adverse impact. What's the evidence in regards to calcineurin inhibitors in this same area? And there are a number of papers. I've highlighted just a couple and would like to point, I think probably the paper from Hojo many years ago in Nature was the strongest of these. It demonstrated that cyclosporin could induce an invasive phenotype in adenocarcinoma cells that was associated with increased tumor growth and metastases, and pointed out a TGF-beta associated mechanism that was independent of recipient immune cells. So the question arises, of course, is do these adverse impacts basically on HCCs in the lab translate to the clinic? A paper here from Vivarelli, who looked at 70 patients with HCCs treated with cyclosporin-based immunosuppression. They had 10 of them that recurred, carried out a univariate and then a multivariate analysis, and the dominant factor that emerged was basically the cyclosporin level. Patients with a level greater than 190 nanograms per mil on trough were associated with a substantial increase in recurrence risk. This is another paper that looked at the question of calcineurin exposure and risk of HCC recurrence. Here, 219 consecutive Milan patients basically were analyzed, and again, high exposure to calcineurin inhibitors came out as one of the dominant factors, and this basically was equal to either a greater than 10 nanogram per mil level of tacrolimus or greater than 300 nanogram per mils of cyclosporin, and it was along with expected sort of implications of largest tumor diameter and micro and macrovascular invasion. So again, the amount of calcineurin inhibitor seems to be having a major impact on the risk of recurrence. Well, turning the page a bit, we'll look at the other immunosuppressive agent that we're going to consider, and that is the mTOR inhibitor group. There is a large literature on terms of the impact of these drugs in cancer, as well as in hepatocellular cancer and in transplant. Some of the early basic science papers, I think, were very important in terms of pointing out how this was occurring, and a couple by Marcus Guba, I believe, deserve to be mentioned. First, his paper in Nature Medicine in 2002 that demonstrated that rapamycin basically inhibited tumor growth by an anti-angiogenic mechanism that involved blockade of vascular endothelial growth factor signaling to endothelial cells. And a follow-up paper a few years later in Blood that showed rapamycin selectively induced extensive local microthrombosis of mouse tumor tissue vasculature and found this was by a tissue factor in the presence of VEGF. A few illustrations from that paper. First, we see here a rich capillary plexus in the peri-tumor tissues of patients, of the mice on rapamycin. Similarly, a very nice plexus in the tumor itself in the control group, but if we look within the tumor in the rapamycin-treated animals, we had extensive loss of vessels, and grossly this correlated with tumor necrosis in the mice. This is a table taken basically from information in a recent publication from Duveau and Tozo that basically put together a whole group of papers that demonstrated preclinical evidence for an anti-tumor effect of mTOR inhibitors in HCC. And they ranged from basically human HCC cells in culture to implanted HCC cells in mouse and rat models. And both everolimus and sirolimus basically demonstrated a range of different anti-tumor impacts, and you can see a substantial number of papers that have come forward with that information. Of course, the question again is how well does this lab-based information translate to the clinic? I think one of the more dramatic papers that in fact shed some light on this is the one published many years ago in the New England Journal of Medicine, where Stallone reported on a series of 15 patients who had developed Kaposi's sarcoma after kidney transplants under cyclosporin, mycophenolate, and corticosteroids. And when these patients basically had their cyclosporin replaced with sirolimus, with rapamycin, over the course of 6 months, 15 out of 15 completely cleared their Kaposi sarcoma. And the illustration on the top is one of these patients after only 1 month of that changed therapy. Another publication from Kaufman, which looked at some 33,000 patients in the SRTR registry and demonstrated that those basically treated with sirolimus had a lower rate of de novo malignancies and of de novo non-skin solid malignancies as well. And a second paper here by Vivarelli again, this time looking at two groups of patients, 31 each, that were matched for a year of transplant, tumor histology, and AFP. And sirolimus here was utilized in patients that were felt to have high risks for recurrence. But despite that, the group of patients with tacrolimus at a reduced dose and sirolimus basically had a significantly improved disease-free survival. Our own group carried out an analysis of the SRTR database on this point, a study led by Christian Tozo, basically 2,500 some odd HCC patients as well as 12,000 non-HCC patients. The large majority of the HCC patients, of course, in the SRTR is within Milan. And we carried out a univariate followed by a multivariate Cox regression analysis. And the bottom line of that study was that we basically demonstrated a substantial impact of sirolimus in this patient group with benefit, also, however, with anti-CD25 induction. Interestingly, however, it was really only in the sirolimus patients that there was a selectivity of this impact. You can see the non-tumor patients, no benefit from sirolimus immunosuppression, but a statistically significant impact here in the tumor patients only. And if we quantify that, in fact, within this study, we showed that there was about a 15% survival advantage at 5 years for the patients treated with sirolimus-based therapies. Now, not all the evidence, of course, in the literature goes in the same direction. This is a more recent SRTR analysis of some 4,000 patients with HCC. They did not find any difference in all-cause mortality associated with immunosuppressive drugs. There was a trend to a lower HCC resistance in the patients receiving sirolimus, but it did not reach statistical significance. So certainly lots of controversy still. And finally in this area, a meta-analysis that's come out just recently looking at mTOR inhibitors in HCC. Zhang pooled 11 different studies with almost 8,000 patients and found that mTOR inhibitors therapy was associated with a reduced risk of HCC recurrence, reduced recurrence-related mortality, and improved disease-free survival at 1 year, and a trend to improvement at 5 years, and an improvement in overall survival at 1, 3, and 5 years. So what evidence basically have we put out there then that immunosuppression can impact outcomes after liver transplants for HCC? Well, first, there's relatively limited data on steroids and anti-lymphocyte agents, but it certainly does suggest an adverse impact. Secondly, calcineurin inhibitors have been demonstrated to have adverse impact on cancer both in vitro and in dose-related adverse impact on HCC recurrence and survival in clinical series. The mTOR inhibitors have demonstrated multiple mechanisms of anti-tumor action in vitro, and both sirolimus and everolimus have been associated with reduction in HCC recurrence and improved overall and tumor-free survival in several single-center retrospective reviews of HCC patients. And our own SRTR database review demonstrated a 15% advantage at 5-year survival in the group receiving sirolimus immunosuppression. Now, the challenge, of course, with many of these studies is that they're retrospective, and there's certainly opportunity for bias. And so I'll turn now to, I think, what is the best information we have available, and that is the randomized control clinical outcomes from the SILVER study. This was a study headed by the University of Regensburg in Germany. It was an investigator-originated protocol and looked at a prospective, randomized, open-label international trial that compared sirolimus containing to mTOR inhibitor-free immunosuppression in liver transplant patients with HCC. There were a total of 525 patients enrolled, and a full 97% of those were able to be utilized in the ITT analysis. Protocol highlights: these were adults with histologically proven HCC, and after a run-in period of 4 to 6 weeks of mTOR inhibitor-free immunosuppression, they were randomized to protocols of immunosuppression that were either mTOR inhibitor containing or mTOR inhibitor-free, and otherwise they were center-specific. The sirolimus targets suggested were between 4 and 10, and those achieved were relatively modest, around 6 nanograms per mil. The primary outcome of this study was recurrence-free survival at 5 years, and that endpoint was not reached. Unfortunately, a lot of the reviews or comments that I've read on this study since that time basically stop right at that point. And I think it's important to realize that the SILVER study was both planned and powered to analyze a series of secondary outcomes as well. And those included recurrence-free survival and overall survival by year post-transplant, as well as outcomes in low and high-risk groups as basically split by Milan criteria, also looking at age, pre-op local regional therapy, monotherapy, etc. And I'll go through some of those secondary outcomes now. So again, the disease-free survival at 5 years, which was the primary outcome endpoint, although there was a 7.5% survival advantage for the sirolimus-treated patients, that did not reach statistical significance. But what did was disease-free survival at 1 year and 3 years, as well as overall survival at 1, 3, 4, and 5 years. All of these a benefit in the sirolimus-treated patients. And the median survival advantage across these 5 years of follow-up was 7.9% per year. If we put that in perspective, I think most of us would be very pleased if we had a new anti-rejection drug that came on the market that could give us a 7.9% improvement in survival. So I think it is certainly an important outcome. Additionally, when we look at just the low-risk patients, those within the Milan group, the impact is in fact much more obvious. And here we see that disease-free survival as well as overall survival at 2, 3, and 4 years were all statistically superior in the sirolimus-treated group. And here, when we look at just the low-risk patients, the survival benefit, in fact, was 11.2% across these years. So in terms of the subgroup analyses, as quite a surprise, I think, to the investigators in this study, the high-risk patients, in fact, did not show any benefit from sirolimus treatment, suggesting that this type of immunotherapy alone is probably not going to be sufficient for the higher-risk patients. But one of the other subgroups that is interesting to look at is the group that was able to basically be maintained on monotherapy sirolimus, and it was about 20% of the patients in the study. Here, in fact, the impact was even greater, with almost 15% higher recurrence-free survival and 13% higher overall survival at 5 years when compared to the combination therapies. A post-hoc analysis was also done looking at basically what this meant in terms of survival advantage for these patients, and the 7.9% higher median overall survival basically equated to a 7-month survival advantage, or looking at it in other terms, about twice what was achieved with sorafenib. How about adverse effects? Well, in terms of major adverse outcomes, they were actually quite even. Importantly, hepatic artery thrombosis, no different between the two groups, and in fact, if anything, a lower portal vein thrombosis rate and lower rates of renal dysfunction. There were, of course, substantial rates of complications in terms of side effects that we commonly associate with the mTOR inhibitors. The bottom line from the authors basically was that they felt that practical incorporation of sirolimus into an immunosuppressive regimen for liver transplant recipients with HCC improved recurrence-free and overall survival in the first 3 to 5 years after transplant. The impact was markedly stratified with Milan criteria, to the surprise of many of us. There was no evidence of benefit in high-risk tumors, but an 11.2% median survival advantage in the low-risk patients over years 2, 3, and 4. Excuse me. In addition, those patients that could be maintained with monotherapy basically had an even greater survival benefit of 13 to 15% at 5 years, and the survival advantage in terms of time across all of the patients in sirolimus equaled 7 months. So how would I put this information together and suggest immunosuppression for patients with HCC? Well, first, I think that anti-CD25 induction should replace steroids and ALG. We should be minimizing our calcineurin inhibitors, relying on mTOR inhibitor-based maintenance immunosuppression with a target range at the upper end and delayed 30 days to try to avoid some of the side effects. Mycophenolate use as an adjuvant to try to achieve these goals. Well, what can we basically accomplish with this sort of an approach? This is a series of patients that we've been basically following, consecutive series of patients transplanted at the University of Alberta and the University of Geneva over the last decade. We now have a total of 322 patients with HCC selected by the TTV 115 AFP 400 criteria, and our mean follow-up is now over 5 years. 75% of these patients were started on mTOR inhibitors at some point, and fully 55% remained on them after a year. The HCC recurrence rate to date is 8.4% with that 5-year follow-up, and of those within Milan, the recurrence rate 5.4%, and in the patient group with beyond Milan, 13.6%. The 5-year overall survival is 89.4%, and the 5-year disease-free survival 85.4%. So I think this is additional evidence to suggest this type of approach certainly can work in patients with HCC. Again, I think there's no role for steroids or ALG in these patients. Anti-CD25 induction appears superior. Mycophenolate use is basically an adjuvant to try to achieve the goals of a minimization of calcineurin inhibitors and basically mTOR-based immunosuppression. Monotherapy if tolerated, try to shoot for the higher range, and delayed 30 days to minimize adverse events. Thanks very much, and I'd be happy to answer questions, I think, after the panel.